Hello everyone, thank you for joining me today. My name is Tim Masek and I'm the System Director of Finance for the Warren Clinic. Over the next 15 to 20 minutes, we are going to dive into one of the most fundamental yet often misunderstood financial elements that impacts how physicians get both reimbursed and paid, the relative value unit, or RVU for short. We'll also talk about how Medicare changes to the relative value units assigned to each individual CPT code contribute to the overall economic climate of medical group practices. Whether you're a physician tracking your own productivity, a practice administrator worried about the impact insurance payment reductions may have to the group, a resident preparing for the real-world business of medicine, or anyone else who is involved in healthcare finance or operations, a basic understanding of RVUs is essential. RVUs form the backbone of Medicare's physician fee schedule and impact nearly every aspect of a physician group's finances, including revenue, compensation, and most other operating cost categories. By the end of this session, I hope you'll walk away able to define the three types of relative value units and how RVUs are used in the calculations of Medicare clinical service payments, recognize why the work RVU is more well known than the other two RVU types, recognize the impact the federal budget neutrality policy has on total Medicare physician payments, have a basic understanding of the Medicare physician fee schedule economic trend over time and the financial problem this trend has created, and finally, identify how you can get involved, find more information, and make sure you're getting the RVU work credit you deserve. Let's get started with a brief history of the RB-RVS system. The Resource-Based Relative Value Scale, RB-RVS for short, or RVU Relative Value Unit Model, was implemented by Medicare in the 1990s to replace charge-based reimbursement with the promise of fairness. RVUs do still matter. In many U.S. markets, a majority of the physician revenue and physician compensation is generated from RVU-based payment formulas, whether directly or indirectly. The Medical Group Management Association, MGMA, reports in its latest survey that the average multi-specialty medical group still generates over 90% of their revenue from fee-for-service models. Let's next define the three types of RVUs. The work RVU is the RVU component that represents the time, skill, effort, and expertise required for a healthcare professional to perform the work. It attempts to take into account factors such as the difficulty of a procedure, the time spent, and the mental and physical effort involved. Of the total RVUs paid by Medicare, the work RVU represents about 50% of the overall RVU value. The second RVU category is the practice expense RVU. This component of RVU represents the cost of running a medical practice, such as office space, equipment, supplies, and clinical staff, including receptionists, RNs, medical assistants, and billing and administrative personnel. This component accounts for the overhead expenses related to delivering the service. Of the total RVU values paid by Medicare, the practice expense RVU approximates 45% of the overall value. Our final RVU category, the malpractice RVU, is the unit that reflects the cost of professional liability insurance for a particular service or procedure. Different types of medical procedures carry different risks, and this RVU component accounts for the variance in insurance costs based on the perceived risk of malpractice claims. It represents about 5% of the overall RVU value. Now that we understand that there are three distinct types of RVUs, let's see how Medicare uses these relative value units to calculate payments for physician and advanced practitioner services. I've selected CPT code 99213, which is one of the most popular office visit codes. It is for established patient office visits that approximate 20 minutes. This is in the clinic setting, and the calculation is as follows. In Oklahoma, the fee schedule 2026 start with the individual RVU values for each of the RVU components we just discussed. In 2026, the work RVU has a Medicare stated value of 1.3. The practice expense RVU has a value of 1.46, and professional liability has a value of 0.09. These base RVU amounts are multiplied by the RVU geographic cost adjustment, which is tied to the specific geography where the service is provided. In Oklahoma, the work RVU geographic cost adjustment has a value of 1. The practice expense cost adjustment is 0.893, and the professional liability cost adjustment is 0.777. Simple math is used to get to our adjusted RVU values. We take the base RVU value for each RVU component and multiply it by the geographic cost adjustment. We arrive at a work value of 1.3, a practice expense value of 1.3, and a professional liability value of 0.07. These values are then multiplied by the current year base Medicare payment rate. For 2026, that rate is $33.40. $33.40 times the work value is $43.42. The practice expense payment equates to $43.55, and the professional liability RVU payment amount is $2.34. We add these three values up and arrive at our Medicare approved payment value of $89.30 for 2026 for CPT code 99213. Comparing that value to 2025, we see that there has been a substantial increase of 6.8% or $5.72. The reason for this increase is that the base relative value for practice expense RVU has gone from 1.35 to 1.46. There's been some small changes to the geographic cost adjustments, but the other major change is that for the first time in the last few years, Medicare has raised the base payment rate. We've seen an increase from $32.35 to $33.40. So the practice expense RVU base RVU value increase and the base Medicare payment increase are what are the two main factors driving our increase for this CPT code. In the appendix that accompanies this slide deck, I have included two additional examples for surgical procedures, comparing the calculations for the 2025 payment to the calculations for the 2026 payment. You will see much different results year over year for the two surgical codes I've selected. Let's recap. We have just learned that there are three types of RVUs: the work, the practice expense, and the professional liability insurance component. We reviewed the role each RVU type plays in setting the actual Medicare payments for the 11,500 unique CPT codes published by Medicare. Though each RVU type plays a similar role in the Medicare payment formula, the work RVU, unlike the other two RVU types, has additional uses within a medical group, which is why this RVU type is much more well known than the other two types. So let's look at two primary reasons why that is. The first is that the work RVU has become the standard to measure productivity. This unit serves as a standardized measure of productivity for the clinical services provided by physicians and advanced providers, nurse practitioners, and physician assistants. It's the physician controllable portion of the total RVU, and it's become the national standard for benchmarking. The second use for the work RVU is that it is a primary metric used for physician compensation. The work RV unit's popularity is also due to its wide use in physician compensation formulas, as it allows medical groups to directly tie physician pay to physician productivity. There's two primary methods of compensation that have an RVU component. The first is the direct RVU compensation formula. These formulas are most popular within health system medical groups, and the compensation is directly based on the annual total number of work RVUs generated. Within private practices, it's more typical to see an indirect RVU compensation formula. These formulas are based on the collected revenues, which are derived from RVU-based fee schedules, less assigned practice expenses. Now that we have an understanding of the three types of RVUs, how they're used to calculate Medicare physician payments, and we have reviewed the additional uses for the work RVU, it's time to introduce the antagonist of our Medicare physician payment and RVU story, the federal budget neutrality policy. The purpose of this federal policy is quite simple. Its purpose is to make sure that any annual budgeted physician fee increase is offset with a materially equal payment decrease. If we imagine Medicare as a pie where the total money budgeted each year to pay physicians and APPs under the physician fee schedule is essentially capped like the slices of a pie, we can begin to understand the impact of budget neutrality. This policy requires any new Medicare physician spending to be offset by equivalent savings, therefore maintaining fiscal balance. Said another way, the size of the Medicare financial pie cannot materially change year over year. An example of this would be if we were going to have an increase in primary care is going to get a bigger slice of the pie. A smaller slice will have to be cut somewhere else. Let's now review the impact of the budget neutrality policy has had over time on the work RVU values assigned to some of the most frequently used CPT codes. The relative values for evaluation and management CPT codes have increased significantly compared to changes for many procedural and surgical CPT codes. The chart to the left shows that. If we look at evaluation and management codes 99213 and 99214, the relative work value in 2000 was 0.67 and 1.1, and those values now in 2026 are 1.3 and 1.92, a change of 94% and 75% respectively. If we look at similar favorite codes of other specialties, we'll see that many of these codes over the 26-year period have seen decreases. The large value changes over time for E&M services represent Medicare's long-standing concern that cognitive services like office visits, consultations, and chronic care coordination were initially undervalued compared to procedural and surgical services. A dramatic way to look at this is let's price the total knee surgery in terms of office visit 99213. In the year 2000, a total knee surgery price in terms of CPT code 99213 was 32.06 office visits. In 2026, the price or the relative value of one total knee surgery priced in terms of CPT code 99213 is only 14.7, a change of 54%. So this begs the question, is one total knee surgery CPT code 27447 correctly priced at just under 15 office visits 99213? I'm not sure if it's priced correctly or not, but I do know that it's in the year 2000, it was probably overpriced at 32 office visits. Now that we have a basic understanding of the Medicare physician payment system, let's review the overall economics of the Medicare physician fee schedule by looking at the trended history of Medicare physician payments versus the operating cost of a medical group. On this slide, we have two separate analyses that help us understand the major financial problem that we are facing today in our industry. The slide on the right, coming from the Federal Register or the federal government, shows two line graphs from 2001 to 2025. The blue line shows the cumulative change in the practice cost over this 24-year period. And you can see that there's substantial increases year over year to the point that the cumulative change in practice costs from 2001 to 2025 is just under 60%. Now let's look at the red line. The red line represents the cumulative change in the physician payments. Physician payments have trended much narrower, and you can see overall that through the year 2025, the cumulative change in the physician payment is under 10%, somewhere around 7 or 8%. When we adjust the physician payment for inflation and practice costs, Medicare physician payments declined 33% from the year 2001 to 2025. Let's look at another similar analysis that shows similar results. The American Academy of Dermatology did their own analysis comparing Medicare payments and Medicare practice costs from 2001 to 2025. Medicare payments, the Academy of Dermatology found, increased 111% over that time, while practice cost increased 59%. The percent change is 48%. If we calculate Medicare payments in terms of adjusting for inflation, we take minus 48% divided by the increase in cost, we arrive at a very similar number that the federal government did. Adjusted for inflation, Medicare payments to dermatology decreased 30% over this 24-year period. I think it's important to test the assumptions around practice cost. Practice cost accumulation of 59%, is that reasonable? I have pulled a couple of cost components that most medical groups will see. One is the occupancy or rent cost per square footage. In 2001, it was $20. In 2025, it was $26. This represents a cumulative change of 30%. A little bit below the 159% we see overall, but let's take a look at another cost category. Medical assistant pay, which is prevalent in most medical practices. Medical assistants had an average pay of $23,000 in 2001. That has ballooned to $44,000 in 2025, and that represents an increase, cumulative price increase of 91.3%. So I think based on this information, supporting information, that the practice costs are substantially outpacing the Medicare payments. So what does that mean for us? Well, it definitely means we have a problem. Without immediate fixes that work to close the gap between cost and revenue, major financial pressures within medical group practices will continue. There are a few possible revenue solutions, including the following: annual inflationary payment updates, budget neutrality reforms, including lifting the cap on Medicare physician service spending, and moving to alternative payment models, including simplifying MIPS, or the merit-based incentive payment system, and introducing and expanding other alternative payment models. Make them more available for all physician specialties and geographical regions, and by all means, make them simple. The first step toward any solution is to admit we have a problem. The next step is to define the ways we can collectively influence the change that is so desperately needed to the Medicare payment model. So how can physicians get involved to help influence the payment changes that are so desperately needed? There are many ways to get involved. I have included two on this slide. I've classified them as external solution participation and internal solution participation. And the external solution participation, engage with your National Medical Specialty Society. Respond to surveys when your society requests data on specific CPT codes, new, revised, or potentially misvalued. These surveys ask practicing physicians to compare time, effort, skill, stress, and complexity to benchmark services. Your responses directly inform their recommendations. The second way to participate with National Medical Specialty Societies is to volunteer for your society's advisory committee, coding reimbursement committee, or advocacy arm to provide input on surveys, data, and positions. If you don't want to participate with your medical specialty society, want to submit your opinions, you can do that by submitting public comments directly to Medicare using easy-to-find links on the Medicare website. The second category of participation and influence for the physician is the internal solution. Partnering with your medical group's operating team, you can partner on initiatives to find practice revenue solutions focused on both volume and value. Said another way, moving toward alternative payment models. And you can also partner on initiatives regarding practice stewardship, help cut waste, and increase practice efficiencies. All right, in conclusion, where can you find more information on RVUs and Medicare payments? I've listed three of my favorite places. The CMS, or Center for Medicare and Medicaid Service website, has great information on historical RVUs, current trends, survey results, much information that help you understand Medicare at a much deeper level. Medical societies we've talked about, they provide valuable information and is shared by most medical societies in the form of position papers, survey results, and other educational materials in your medical record. Your company's electronic health record has many useful reports that can help provide insights into the productivity and revenue of your clinical team. 3 proven tips to get the maximum RVU credit for your work. Everyone that's paid on an RVU-based payment system wants to get the most credit or the accurate credit for their work, and there's 3 proven ways to get that credit, in my opinion. The first is accurate and complete documentation for services rendered. If we don't have the documentation, you cannot bill for the code. The second is to make sure we're coding for all services rendered. And finally, and sometimes I think this is the underlooked but more important step to maximize the RVU credit for your work, but it's to create efficient scheduling template for how you practice. If you can create the most throughput for the patient, then you are able to generate more visits, which typically lead to more work RVUs. And in conclusion, my key takeaway for this presentation is the definition of RVUs. And RVUs are finite relative value resource measure that attempts to capture and measure the value of work and cost of clinical teams. It will continue to impact reimbursement, compensation, and productivity, and without a fix that closes the gap between practice cost and professional service revenue, financial pressures to curb medical practice cost increases will likely persist. I've enjoyed our time today. As we move forward together, the focus on and the importance of RVUs will most likely continue in the near term, as RVUs remain a powerful tool used by Medicare and other insurance payers to drive change and to manage the overall payment budgets for the clinical services provided by medical group providers. But like any tool, it's only as good as it's used by our elected leaders and ultimately by ourselves within the business of medicine. I want to thank you for viewing this presentation today. I'd love to hear your questions, experiences, and thoughts on these topics covered today. Please feel free to email me to start a conversation. I look forward to hearing from you. Have a great day, everyone, and thanks again.